The aim today of our lunch conversation is really a continuation of conversations that began yesterday and actually with the talk this morning that Lauren Taylor gave. That was fantastic. Both the panel yesterday and this morning's talk were great about setting us up for the moment in time we're in and what does the sort of future hold for us. Before I share a little bit about this session, I'm just going to give a brief introduction of Stuart and Len, and I think Len's going to be joining us virtually, so he'll be floating above us on these large screens shortly. My intro will not give Stuart and Len, it won't do justice to their amazing accomplishments. Stuart is a scholar in residence in economic studies at the Brookings Institution. Prior to joining Brookings, Stuart spent 35 years at the Heritage Foundation as director for the Center for Policy Innovation, and earlier as vice president for domestic and economic policy studies. He's also on the board and visiting fellow of the Convergence Center for Policy Resolution, and has had a variety of advisory and other roles throughout the halls of government. Let me also introduce Len, who will come up and would love to give them a round of applause. Len Nichols is a non-resident fellow in the Health Policy Center of the Urban Institute and professor emeritus at George Mason University. He was the director of the Center for Health Policy Research and Ethics and professor of health policy at George Mason. And he's been intimately involved in health reform debates, policy development, and also has worked throughout the halls of government in OMB and in the Clinton administration. I'll say both of these gentlemen have forgotten more about health policy than I will probably ever know, and I'm very excited to sort of just be on stage with them at a conference thinking about how we continue to do work as operators, as researchers, as policymakers in this arena of social care, and what does that mean in the US. So first, let's give our esteemed panelists a round of applause. And Len, just checking in, can you hear us okay?
Gotcha, Anand. Very good. Thank you.
Okay, great. Well, I'm just going to give some brief remarks and start with a couple of questions. If we build on the panel that just yesterday evening, where Laura, Rishi, Lowell, Megan, I think really reflected on how social care has changed over the last 15 years, and both the acceleration, some of the opportunities and challenges, the proliferation of social risk screening, the change in the 1115 waivers, the approval of the Healthy Opportunities pilot in North Carolina, the Accountable Health Communities findings at CMS, and a variety of other changes, including quality metrics by NCQA, HEDIS, the Joint Commission, CMS. And there's a rapid proliferation of change, and amidst that change, I think we're trying to understand what are the lessons that are working, what's working well, what's not working well, where do we need to do work. And we're also in an political environment where there's a new administration and new Congress, and we're certainly feeling that change over the last couple of weeks. There's been a tremendous amount of information coming out. And so our aim is really to just talk about that broad landscape. And before we maybe talk about where we're headed and where we are today, I think I'm going to start with a question I'll start with Len and actually go back and forth and say, Len, can you tell us about your perspective on some of the changes in the environment and achievements that have happened in social care over the last 5 to 10 years that sort of bring us into the moment that we're in today?
Well, thanks, Anand, and thank you all for letting me pipe in virtually. For me, the number one achievement over the last 5 years has been the spreading awareness of, I would say, the impact of social care and the impact it has on health and healthcare costs. And I would be remiss if I didn't mention the reality that SIREN's own curated bibliography, that database is phenomenally useful. And I'll tell you why. When you give a talk about this stuff and people look at you like, well, there's more than one study, I hear it doesn't work, yada, yada. you whip that SIREN webpage up there and you show them what's there and they go, oh, well, in that case. So it really is a huge infrastructure that's quite useful to researchers and real people. The second thing to summarize, and it sounds a little weird, but it does summarize what's going on, and that is this week, the American Academy of Actuaries created a panel, a study panel for themselves on social care. And they want to talk to me. Okay, now that's proof they're desperate and they haven't yet got to all y'all smart people in the room, but it's also proof of a changing, shall we say, perspective. And a perspective, and they want to talk to me, by the way, about this paper I just wrote with urban colleagues, published in Health Affairs Scholar. I think there's a link to it in your app. And that paper basically goes to some effort to show that if you look at benefits across the various stakeholders from social care interventions, the sum of those benefits often exceed the cost. It's true that there are not enough healthcare savings to pay for utopia, but it's not true that a lot of stuff doesn't pay for itself. And if you do the accounting and the math and the economics right, it turns out a lot of this stuff, like, for example, permanent supportive housing, more than pays for itself. And as you know, Anand, there's a term in economics for things that should be done but aren't done when we know it's worthwhile doing, and it's called stupid, okay? And while actuaries are not widely known to be, you know, as creative and progressive as we might like, they don't want to be stupid. And the point is, they've created a structure to work within their own institutions to change the way they think about this stuff, and so God bless them. That's what I'm happy about.
And Stuart, do you want to add?
Well, Len, I just want to tell you that you are looking down on me like Big Brother. So I'm suitably concerned. Also, Len and I have known each other for many, many years, really since the Clinton administration, where we went around the country on both sides, or each side, if you like, and we got to know each other. And coming from Britain, I didn't unfortunately have Google Translate to understand Arkansas, but Len taught me it over our period together. So we've known each other a long time, so we're not on opposite sides or anything like that. But he's a real economist, and I'm an historian, so we kind of complement each other a little bit in terms of how we look at these things. I would say, you know, I've really been working pretty strongly in this area for probably the last 12 years. And if you go back just 10 years, I mean, you really had to sort of explain what social determinants and social care and what its connection was. I mean, people just didn't kind of get it. I think in the last 5 years, we've really moved to a very important stage where organizations and individuals and policymakers are saying now, how do we actually do this stuff? And what do we do? And Lauren raised a lot of the issues about who should be doing what and so forth. And I think that's what we're really seeing now and where we are. I think, first of all, there's been a really important appreciation that in order for us to address social care in the way that makes sense, including healthcare, is actually to look at institutions and institutional change as well. So the whole idea of hubs, which there was a breakout session on, how do we set up locally the kinds of partnerships, and what kind of institutions can do that? Can institutions that actually exist help in that? We do have a lot of focus now on school-based mental health, for example, seeing schools as critically important places. We see FQHCs, clinics, widening what they're doing. I was on the board of a FQHC until fairly recently in Washington, D.C., and it's providing social services directly. It's got a partnership with a charter school, which is a two-generation charter school. So there's a lot of focus now on exactly kind of what structures need to be put into place. I think also, as has been said, and I'll just say this briefly, the whole issue of the business model of how do we actually make the money work so that it makes sense for KP, it makes sense for others as well to work together. And we still got a lot to do there, and it affects public policy as well, because payment systems, how grants are provided, and so on, all of that now is really under discussion in a way that it wasn't before. And then I think that also the whole area of data, I mean, the recognition that that data is so critical to getting referrals and to collaboration. And there's a lot that needs to be done in that area. We have organizations, of course, CBOs, that very often don't have the capacity. We have systems that don't talk to each other. There's lots of issues. We'll probably come back to this in terms of how we move forward. So I think we're at an exciting stage of moving from really talking about just convincing people to saying, now, how do we actually do this? And recognizing that that means lots of rethinking in multiple areas, and not just in the health sector, but in the social service sector, in housing, and so on.
Yeah. Thank you for that. And I think we're going to come back to many of those actually topics that you raised. Let me, I think, come back to the notion of a lot of this work is influenced by the environment that we work in. And this morning, Lauren gave us a really great framework to think about, you know, the fact that we probably operate in a non-ideal state, and you may want to work towards an ideal state, and you have to develop, I think, for yourself what some of those actions are and the direction that you move. So we're coming into an environment where we have a new presidential administration, new Senate, new House of Representatives, and policies are being enacted. I guess maybe I'll start with you, Stuart, to say, with the sort of new policy environment, what are the opportunities and risk for this work to proceed? And Len, I'd love for you to chime in as well.
Well, I think Anand, new policy environment is like a British understatement. I think the person, one of the people asking a question, Len, this morning, talked about a period of shock and awe, going back to Operation Desert Storm, and that, as somebody who lives in Washington, that's what it feels like. It's very different, I think, in terms of where we are. And of course, there are immediate risks that that many of you, I'm sure, have seen directly and probably had emails from the federal government telling you various things not to do. There's certainly going to be an enormous effort to reduce spending, particularly in the Medicaid program, which is going to have enormous effects on well, how much can we link together Medicaid and social services, and how do the institutions work? That's going to happen. So there's a lot of bad news that's going to come, and I just want to make that clear. And there's just a lot of confusion associated with this. But I think, in a sense, the good part, or how do we sort of, I'm a perennial optimist, so I always try to look for what's the silver lining, no matter how black the cloud is. And I think there are some areas. I think we will see, and I think there'll be a fair amount of enthusiasm for a continuation of experimentation with state-led efforts, particularly through the 1115 program. Let's remember that North Carolina's 1115 waiver was put into place under the previous Trump administration. So the idea of saying, look, let people further down the system figure it out. If you're trying to reduce Medicaid and try to make money go as far as possible, it makes sense to allow states to have a lot more opportunity to experiment. So I think that's definitely going to happen. I think the whole idea of localism, of trust people locally, is very much a theme of this administration, at least a sub-theme of it. And so ideas of looking at hubs, looking at other kinds of initiatives locally, there will be an openness to that to a certain degree. You've got to be careful about the language that you use. Any of you have websites that have the word equity, get rid of that. Any of the others, because that's the way the world is right now, of words matter. So use the right language, but I think there's opportunities there. And I think there's an opportunity for, particularly among social service providers, for faith-based organizations to be trusted more by people in this administration. And there's a lot of interest among organizations like Catholic Charities, Lutheran Services of America, and others about having formal engagement with Medicare Advantage, with the Medicaid program, and so on. And I think that's an opportunity that we have in this area. So there's opportunities here, but you have to be careful how they're described and the purpose. And again, we may come back to that a bit later on.
Thanks, Stuart. Len, do you want to chime in on my understated question?
Well, I would just iterate Stuart's point about the understatement. I mean, the risk of an FMAP cut is potentially catastrophic. But, given that risk, I would say two things, and to flesh out a little bit what Stuart said. It's important for people who disagree with him to remember ours do want to spend less money in total. And financing social determinant interventions collaboratively can help them do that. So you got to take what we got and work it into, this is why it's in your interest. And second, I think it's fair to say ours believe in the private sector. And therefore, public-private partnerships and state-led and community-led things are going to be more naturally attractive to them. And therefore, I would emphasize again that collaborative nature of a public-private partnership and how that can further everyone's goals. You got people at the top who believe that the world is zero-sum. Everybody in this room knows it's not zero-sum. And at some level, our task now is to convince some people in this administration the world is indeed not zero-sum in a particular case we're trying to argue about at the moment.
Yeah, let me maybe follow that thread and in some ways pick up on a comment you made, Stuart, earlier about one of the key questions really as we continue this work aligns with, well, then how do you fund it? How do you continue it? What is a sustainability model? And Len, you've done a lot of work talking about, including maybe you can describe some about the paper that you published recently about how folks can actually think about quantifying return on investment and value in different ways. So I guess I'd love for you to maybe help us frame what it means to think about financing and value and return on investment in this arena in a way that can be a guide post for us to do this work moving forward.
Well, I think it's fair to say this is the $64 trillion challenge, right? But, and the real issue is how do you make it sustainable? And in my opinion, financing is sustainable only when it's in the payer's self-interest. It's got to be in their self-interest. Charity alone will not get us to the promised land. Now, Lauren Taylor and I have spent years trying to make clear that social care interventions really are like public goods. They benefit multiple people simultaneously and unavoidably. And that unavoidable fact means there's a free rider problem and that people can benefit without contributing anything, and therefore everybody invests too little and some invest nothing at all. And that describes our situation. Therefore, for the proper amount of resources to get upstream of the healthcare system, we're going to have to use collective action or collaborative financing tools of some kind. Taxation and government spending is one of those tools. But for various reasons, some good, some not so good, a lot of our people don't trust government to do this anymore. And that's exactly why Lauren and I invented caption, because we saw it as a way to get around that fear of government and a way to build in the natural solution to a collective problem, which is collaborative financing. And it's a governing tool as well to help people make decisions. So that's why I think fundamentally, when you look at on the ground, who could benefit from a proper social care intervention? Hospitals, health plans, law enforcement, schools, employers. You get all them together and you say, okay, look, if you do this, you can have this benefit. If you don't do this, you can go your own way and good luck. Now, it's true that and CAPI's not the only one by far. There's all kinds of little bond tricks run around, all of which are clever, none of which have been taken to scale, nor has CAPCI been taken to scale. And I would argue, given the public good nature of the financing problem, though, you've got to have collaborative financing to address this public good, or you're never gonna get to where you want to be. On the quantification of the ROI point, what I found interesting, Anand, is as we went around the country and did this stuff, and we're doing medically tailored meals in Cleveland, we got shots in arms in Albany, New York, we put a social worker in a police department in Waco, Texas. Okay, so very different interventions. But in every case, what you see is the data that are necessary to convince the stakeholders of the impact the intervention's having are in their own systems already. You just have to show them where they are. You just have to connect the dots to what you did in the intervention. So it's not a big mountain. It's just a matter of getting folks to look at their own data in kind of this creative way. And I would just say, police chiefs are among the most creative people in the country because they got a problem you can't solve, and that is they don't have enough resources to do what they need to do. And if they can do it in their data systems, Lord knows health plans and hospitals can too.
Yeah, I mean, Len, of course, is absolutely right on all this. And Len and I wrote a piece a few years ago, actually, on what we call co-opetition, or what is called co-opetition. The notion that even competing organizations can find it in their interest to actually finance some common activity that increases the value to all of them. You think of something like Restaurant Week, where restaurants get together and say, well, let's all put some money into advertise Restaurant Week. They're all in competition, but it makes sense to do that. And I think building the infrastructure, as Len and I said in this piece, building the infrastructure of collaboration, of partnerships, of data transfers makes sense even for competing health institutions and other kinds of institutions. So I think that's a very important kind of concept that's got to be part of how we drive forward. And I think that leads to a couple of things, which I'll just say quickly. One is, as Len said, we've got to explore the whole area much more than we've done of the social return of investment, of any investment in directly into social care, say by medical facilities. When Kaiser Permanente invests in housing, of course, it affects the bottom line, it affects healthcare, but it also affects the need to provide housing for people. It affects, as Len said, very often crime control, mental health, and so on. So we've got to do a better job, and this is where the researchers in the House have got a lot to do, to refine those models, those techniques, so that it becomes easier to identify that. Then the corollary of that is then how does that drive change in both business decisions and in public policy? I think it's got to make good business sense, and looking at social return on investment and the wider the wider influence of these partnerships really underscores that. The other part that's really important is in the public sector, and that's the whole issue of the budget process, whether it be at the federal or the state or the local. Today, if the health sector invests in something that improves, Len mentioned policing and so on, reduces crime and delinquency and so on because of an intervention in mental health, for example, there's no payback, there's no savings that accrues to the sector that's making that investment. We call it the wrong pocket problem. You're very, very familiar with it. And we're beginning to see efforts to try to deal with that, to try to look at methods. Some counties around the country are essentially taxing different departments that are affected by collaboration and saying, let's have this pool of money that we'll use to actually invest in it, rather than trying to get one department to do something that really benefits another department. So there are techniques like this that need to be explored. So I think researching on the social return on investment and looking at these budget process changes at all levels are essential to turn what, and I've just been saying, into actual practice.
Yeah. We're touching on a lot of big topics here. It's almost like a survey conversation of many of the major levers that influence this body of work. We'll have time for questions, so be thinking about questions that you want to ask Len and Stuart, but I'm going to maybe continue on in terms of this, broad-ranging conversation. I think one of the things we talked about maybe reflecting on, it feels like a long time ago, but in some ways may provide some instructive lessons. During the COVID-19 pandemic was also part of the time that social care really grew in dramatic ways, and some of that may have been the visibility of disparities and other health outcomes. But it was certainly one of the, I think, underlying environments that we were living through, and it was an unexpected change to the environment. And I guess I'm just curious, in this moment of time, looking back, are there any specific lessons that you think we should be taking, from the pandemic and that period of time into the future? And maybe either one of you want to start?
You want to go, Len?
Well, you said it, Anand. I think the fundamental lesson from COVID for this conversation is how many people learned about the reality of inequity. I mean, I remember, COVID happened, I couldn't fly to my research sites anymore and all that stuff, so we just switched to Zoom. I taught classes via Zoom. I got paid in the mail, in the bank account without even a blink, right? But the people who brought me food were barely making a living wage. And I remember being just incredibly conscious of that and thinking, oh my God. And then we started looking at the statistics of who COVID killed and who wasn't getting shots and so forth. And to me, what it did was drive a much wider awareness, which made our job easier to convince people to think about the social care issues. But it also drove a sense of urgency among, I think, a lot of us and among policymakers as well, at least policymakers in the previous administration, who really wanted to solve the problem because it became manifest in a way that you could no longer deny. And I think people were shocked at how the intersectionality, to use a word that will also be banned soon, I'm sure, but that's true, right? Because it was people who were still working, delivering food and working, and they got COVID at work, brought it home to their more densely populated multifamily arrangements, and so it was just a perfect storm.
We learned a lot, of course, through what happened in nursing homes about the reality of social care and who provides social care, not just in those settings, but in lots of other settings. A lot of immigrants, and we've got a policy now to try to get rid of them. Fortunately, I've been here long enough. I became an American citizen, so I'm okay. But that's one. And then how low paid, as Len said. So I think that was a critical lesson about the importance. But who are the people who are providing social care? I think also the importance of family care and linking social care to family care really came through loud and clear, particularly with older people, but more generally. And then I'd say the other thing that I don't know that we've made enough of yet, but the technology, we mentioned Zoom, of course, but the use of telemedicine or telehealth, I think is still at its infancy in terms of what that technology can do. For instance, in the FQHC that I was on the board of, we use what we call facilitated telehealth, and that really grew up during COVID. And that involves not just having a patient or a person and somebody at the other end who's a healthcare provider, but somebody sitting next to that person who is a trusted social worker, social care provider, neighbor, and so on. And it changes the relationship. It is a kind of a mini trusted hub in the living room of that person. And we used it extensively, for example, to encourage people who are new to this country, like pregnant women from Latin America, had no exposure to the American health system, were scared of it, literally scared of it, and thought ICE was going to kind of pick them up if they came in. Probably true in lots of cases. And this introduced them to the whole range of services, not just health services, that were provided, because the person sitting next to them was the person who was trusted, who followed up, who would say things like, what the doctor means is, and then put it not just in the language, but in everyday terms. So I think there's a lot in the technology area where using that to connect and to build trust, it's not something we normally think of as of technology in this way, but to build trust could be a very, very important tool in the future in this whole area of social care, in my view.
Yeah, no, I love these comments, and for me, some of the things that come through is the notion of the sort of resilience that the country demonstrated in those uncertain times in finding sort of a path forward. And to me, I think that feels like part of the recipe that we'll always need to do, whether it's today, tomorrow, or 10 years from now. You made a comment earlier, Stuart, about that you may need to change the language that you use. And so maybe let's come back to that topic a little bit of this work inherently is about helping people optimize their health and well-being. How do you see this work needing to adapt at a time when language is being policed and sort of the connection between equity and disparities? What guidance do you have?
Well, first of all, I think it's very, very important to be unequivocal about the danger about the fact that the wording and phrasing is going to be used very extensively under the administration, and that there are certain phrases that just set off alarm bells to a lot of people. There's no question, equity is one of those, because it is seen by many on the friendly to the administration, it is seen by them as being really a wedge to put massive resources into social care for people who, quote, don't necessarily deserve it or are not working, and so on. That's just one example, but I think it's important to kind of look further. You mentioned I'm involved with Convergence. That's an organization that does bring groups together on a variety of issues to really use the techniques of facilitation and mediation to reach common ground. And we just had a big project, which of course you were involved in and was supported by KP and others, to bring a variety of sectors together, social services, transportation, food, and health, to kind of really look at what is the set of policy changes at the federal, state, and local level that would be needed to really accelerate the movement towards social care collaboration with the healthcare system. Very early on, and this is now a year before the election, we had a discussion about, well, what do we call these things? What language do we use? And we talked to people very much on the progressive side about, let's not lead with equity, for example, because equity is really the result of what we do. If we tackle these issues directly, then the result will be greater equity. Better to focus on the practicalities of change and improvement, and not on some of the words that set off alarm bells. And I think it's unfortunate, but it's really important, I think, for us to kind of remember that very vividly. Not just the word equity, but just there's going to be a lot of assumption about what the intent is of organizations by the language that appears on their websites, by the way you talk about things. So you have to be careful. I think, Lauren kind of touched on this. This is the reality of the world we're in right now. And we wouldn't say things in a certain way if we were in an ideal world. But we're not in an ideal world. And so let's be sensitive to that.
Thanks, Stuart. Len, do you have anything you want to add?
So, well, I have to say, look, it's striking to me how equity is being attempted to be canceled. I got to say how it is that self-proclaimed smart white men can look around this country and think that white men don't have enough power and money and influence and domination. What the hell are they looking at? But anyway, here we are. Here we are. So I agree with Stuart, let's be careful, all right? And I will just add, screaming racist at them is not likely to be helpful, though it is emotionally satisfying. I get that. But I live in New Orleans, okay? And in New Orleans, where I do enjoy living, we have a very nice, I would call it, inclusive phrase. And it comes from our attitude toward life, as well as the way Southerners particularly butcher the English language, God forgive me, Stuart. But we say, all y'all. And all y'all means all.
I have to say, it was Len who taught me that all y'all is the plural of y'all. It took me a long time to learn that, but I got it now. He's
not in the textbook.
He's a good mentor.
I'm appreciating this conversation as a Tennessee and Georgia boy. I haven't heard all y'all in a while, so thank you for that. All right, well, maybe we have a couple more questions, and then we're going to open it up for audience questions. Let's go. I think, Stuart, you talked a little bit about the use of technology, both in COVID and measurement earlier, and I guess maybe I'd love to hear how you think about leveraging data measurement can be a tool for social care work to sort of progress. And what are your thoughts about the opportunities?
Well, we certainly know that data is both a critical tool, and the lack of it is a barrier in practice. of having even departments working together. I mean, if you look at, I think there's something like 27 definitions of the word homeless in the federal system, for example, in the federal government. So actually being able to talk to each other, data is so critical. In fact, in this group that I brought together at Convergence, I would say actually data was the number one thing that kept coming through over and over and over again into how you reward people, activity, how do you measure impact, and so on. So it's extremely important, and we've got to take several steps. I mean, I think it was said yesterday that we have a dearth of, it's so hard for community-based organizations to collect the data that they're asked for. I think there's a very important role for philanthropy especially, but also creative financing like Len and I were talking about earlier, to begin to build the capacity of CBOs to really provide and understand what they're doing and provide the information that's needed to get better referrals and so on. It's also very important, I think, in terms of how we find agencies working together. And very often, you don't see collaboration among different agencies of government at all levels, in part because, again, the people involved in data are not learning from each other and not working together. And one of the spin-offs of this project that I've been involved in is really to bring together data officers in government at all levels, particularly county levels and state levels, to really regularly talk through how to enable data to move across sectors within government in ways that it just does not today. So it's a very, very important area. And then I'd say finally, of course, obviously measuring and evaluations. I mean, we've got to understand if what we're doing is right. Now that's a tricky area because, if you don't have data, it doesn't mean something doesn't work. It means, it was Einstein, I think, who said that, not everything that counts can be counted, and not everything that can be counted counts. So in many cases, we have to use qualitative information to make sensible decisions in the real world that we face. So let's not make data itself become a barrier to innovation and to new people and new organizations doing things. It's very important to kind of keep a balance there, in my view.
Thanks, Stuart. Len.
So I think the big innovation here lately have been these social care closed-loop referral platforms. And in my view, they show great promise. By the way, they don't have to be for-profit, as San Diego CIE shows every day. But I think it's fair to say the implementations of these platforms across the country have discovered a couple of things that are also needed. And number one is, as Stuart says, we got to invest in CBO capacity to manage the data, to collect and manage and process the data. And there's got to be local infrastructure like some kind of community care hub, et cetera. But I also think, and here's where I'll put on my would-be preacher hat, we got to overcome these hurdles that are mostly bullshit about sharing data across platforms, right? We know damn well this can be done, yada, yada, yada. I'd help design a pilot between Ballot Health, which is a big hospital system in Tennessee and Virginia, Unite Us, the Virginia Hospital Association, Institute of Public Health Innovation, with CDC funding, all looking for how to show impact of CHWs. By the way, CHW's moment has come. They've been discovered. Everybody loves them, and they're cheap. They're just wonderful. They're perfect, right? And so God bless CHWs. Well, what this thing showed was, A, you can match patient records from a CHW contact list with the hospital, and you can show impact of the CHW intervention in a real rigorous way. And so that's the key to the future. We've got to get these data systems to talk to each other, bring the health plans in. It can all be done, you know exactly how. Kaiser does it every day. It can be done. We just, in a way, haven't wanted to enough. And I'll stop there and let you close the last question.
No, well, it's an important comment that you all had because the folks in this room, I think, are key to driving some of the conversations forward about how we measure, where we measure. As I ask the last question, I'll say if folks have questions, please come to the mic in the middle of the room. We'll certainly need it so Len can hear the question. So I think the last question is, at this moment of time, what gives you optimism about the path forward, and really what other, I think, comments would you give for folks to consider about how to carry forward some of this work over the next few years?
Well, I think it's hard to be optimistic in some respects, but I think the changes, the changes of attitude, the understanding of the role of social care in health generally is now so embedded among people like you and others in the field that are doing this, that it's going to continue. So I think the most important thing right now is to focus on really two areas in terms of policy, because that's kind of where I work. One is look at what you can actually do already under current law. The Biden administration was very good towards the end in terms of beginning to send out better guidance about what you can actually do and how you can braid money together and how you can do things. Have a look at that and move forward. And then the other thing that causes me optimism is that I think at the bottom line is this is not an ideological issue. This is truly an efficiency issue. It truly is. How do we get the best use of money and the best use of resources to get both better health generally and healthy communities? That's not something that divides us. So I think the momentum is going to continue, whatever happens in the next 4 years.
So, Anand, I take optimism from the commitment to what I call evidence-based equity that I've seen basically following Lauren Taylor around these last 7 years. I mean, it is wide, it is deep, it is in every community I've ever been in. And let me just say, I'm pretty sure I'm the happiest health economist in the country because I spent so much time at the community level because at the community level, you know what? People put their politics at the door. They actually want the system to work where they live and work and play and pray. And it turns out they know how to work together if you help them. I look at my job as teaching people it's okay to collaborate even though they're American. Okay, it is okay. But the game changer that would really make a difference is if we learned how and became wise enough to pay for health and not health care. You know why we pay for health care? Because actuaries couldn't imagine anything else in 1965 when we created the Medicare payment system. That's a fair imagination. And now we got actuaries asking about what we're doing. So I think we're making progress here. Finally, I would say, look, you have to invest in community infrastructure like Stuart and I have said and written and so forth. And the last little policy thing, for God's sake, free Medicare fee-for-service to participate at the local levels. Medicare fee-for-service is still a big program for a whole lot of people. And if we don't figure out how to get it to be part of this conversation, it's not going to be as effective and a lot of people will be worse off. So I'll stop.
All right. Well, let's give Stuart and Len a hand. And they've given us a lot to think about. And I want you all to be able to ask questions. So and I'll let Yuri or someone let me know if we're out of time, but does anyone have any questions? And if so, please come up to the mic.
There we go.
Hi, I'm Rachel Kohler. I was the CEO and owner of NowPow, and which was one of the early on closed-loop referral platforms. I also chair Patient Safety Quality Committee for a big Chicago hospital, and I'm really surprised that value-based care payments are not being, value-based care contracts are not being used to demonstrate the power of social care. And it would put it right back to the payers to understand the benefits. And why can't we get that sort of going out there?
Great. Len, did you hear the question?
Yes.
Okay.
So great question. I'll just say the main reason we haven't been able to get it going as it should be going, I'm with you 100%, is that we haven't figured out how to share the benefit of the value-based savings appropriately. You look at who doesn't want to do it. It's pretty much primary care. And so what's the deal? We're not giving primary care enough of the stake, and they don't feel like they've got the infrastructure to enable them to do well in it. So it's about getting, look, both God and devil are in the details, and the details have not been appropriate to entice the level of effort that I think you and I both think is necessary. Stuart?
No, I agree, +1.
Thanks, Rachel. Other questions? All right, I think
First, thanks to all of you for a great talk. My name's Jessica Ridpath, and I provide communication support for Sonnet, work with Anand and the Sonnet team. And so I'm really happy to hear the discussion of language. I'm hoping to hear more about that this afternoon. I know there's a session on patient perspectives that my lunchmate was telling me about. But the notion of changing the words we use to try to get traction, I think, is really important. And I have an anecdote to share from research a colleague of mine did working with the Delta Center for a Thriving Safety Net, which is funded by our WJF. And they were working in conservative states to try to get health equity on the map. And they found no traction with that. But as soon as they started using words like, we're trying to support and advance rural health, we're trying to support and advance our local socioeconomic health, those policies that had health equity embedded in them were accepted and enacted. So I do think it's important to really think about how language matters and to think outside the box. And I've heard folks saying that the whole conference. The thing that I would really like to see is more understanding of the language we use with the people we're trying to help. So when you're in that moment in a care team visit or giving someone an automated screening on paper or on an iPad, are we giving them language, A, that they can understand, A, that isn't offensive to them, A, doesn't put their walls up, like, why is my health plan asking if I can afford my house? Like, are you gonna kick me off my insurance if I say no? So I wonder about the accuracy of the screening data we're getting. I just wondered if you guys had any thoughts on how can the research community prioritize understanding what our patients and our members need to hear from us to really be able to engage so that we know that we're not causing harm when we don't need to, and we know that we're getting the truth from them.
Yes, I mean, the point you raised about language and understanding is so critical. There's an organization called the Frameworks Institute. I think it's all one word. I forget, you'll find it. The Frameworks Institute. And they do a lot of a lot of research on what people's attitudes are and how do they feel about certain kinds of institutions. They found, for example, that the vast majority of people, when you talk about nursing homes, say things like, oh, that's the place you go to die. You know, they don't think of it as like an extension of family or anything like that. So I think really understanding that and doing research in that area is a very, very important area. You can have brilliant statistical research on what needs to happen and so on. But if people are responding to it in a way that is not moving it forward, I mean, is antithetical to it, then you're not going to make any progress. So language is so, so important in this area. So I would just definitely kind of underscore that.
Yeah, just to pick up on the patient care front point, I would say that speaks to, in my view, the need for a community health worker or some other kind of, if you will, translator, somebody the patient trusts.
Right.
And we have to think about that as part of the team. And it seems to me what the community health workers have done in lots of different settings is demonstrate the trust they have as an asset that can help the healthcare system and the patient achieve what they want.
And that's the basis of the facilitated telehealth that I mentioned earlier. It's having somebody,
Yes, that
that's why it works.
great points. Josh. Yeah.
Thank you so much for the discussion. My name is Joshua Collier. I'm a community health worker and community health worker instructor based in Austin. And so thank you for the shout out to community health workers and their impact. Such an important workforce and one I'm proud to be a part of. I have kind of two questions, but one involves kind of, you mentioned, all y'all, and often when we look at the faces of the people in the rooms designing these systems, we're not seeing all y'all. So that question about how can we increasingly involve the voices of CHWs, not just within the scopes of work that people imagine that they have. I think often people don't really understand what the scopes of work of CHWs and social workers are. They can be much more broad, although they should be defined for and individual CHWs to be able to focus on whatever their particular job is, right? They can be in many settings and have many roles, but just curious on your thoughts in that respect, making sure that there's a greater participation of the people most impacted by health inequity, largely a workforce led by women of color, and as it should be, the people most impacted by health inequities leading those conversations, in particular around data. And I'm curious how HIPAA could be used to protect data from the wrong people while we can still have interoperability. Having done a bit of work with an HIE, I think that's an interesting balance to consider information security and privacy versus efficiency and interoperability. So that was the second part. Thank you.
Let me take a stab at the first one quickly, and that is that as we look more at working together across sectors, bringing people together, thinking about hubs and so on, it creates a strong demand. I mean, one of the critical skill sets is coordination, is who coordinates. And I certainly heard a lot about how CHWs, are trusted in the community, can work together in this way. Somebody in our project, you may remember this, Anand said, when you're looking at a coordinator, there's two criteria. One is the person has to really understand the community and come from it. I think that speaks to the point you made. The second is they've got to be able to get their phone calls returned. And by that, this person meant, if you want to call, if you think the housing authority ought to be more engaged, a CHW may well call, but may not get their call returned, right, from somebody high up who can make a difference. So we've really got to think a lot about coordinators and the profession of coordinating to make this work. And we're still far away from doing that, I think, in terms of exactly how to do it properly. So that's something for you to think about in terms of how do you create a true profession from top to bottom, so somebody's trusted here, somebody up here can make things happen, and they're connected to each other and working closely together. That's what's got to happen eventually.
Yeah, I would just add one thing to think about for that first question is you got to convince the docs that they need the community health workers. Once they see the value that generates for something they're rewarded for, then you got them. They're in the room forever, and that's what you want. On the data, HIPAA, God help us all, I'll just say, look, in a funny way, maybe not a funny way, what's necessary to share data across platforms, et cetera, is trust. Who's going to see my data? Who have I given permission to? Who should? And that trust transcends. So it comes down to how you communicate with the patient, who, by the way, should own the data, and how the rights to those data, if you will, to be used for the good of the patient and the community are distributed across the various stakeholders. And that's where a process that includes all levels of the society in the design is exactly the only process that's going to work, because the only way you're going to have enough trust to get the permissions you need to make the system flow. So to me, it's all of a piece, and it's all about listening to people where they come from.
All right. Do we have time for one last question? Okay, please.
Hi, my name is Rohan Rastogi. I'm a San Francisco-based internal medicine physician and a health policy fellow working within SIREN conducting research. Thank you guys for all the insights. I was really intrigued by the ideas of collective financing. And I think one of the questions that raised for me was who's responsible for starting a collective financing model, and have there been examples of those being implemented to success in healthcare, and how does that work?
So maybe SIREN can give you Lauren's cell phone number, but she's responsible for. So who's responsible is a really great question. Because one of the things we discovered as we did our site visits is, it's no one's day job to put together a collaborative activity. And that's what Stuart and I mean when we say we need to invest in the infrastructure. Right now, who does it? Well, it might be a United Way in some places. It might be an employer group in other places. It might be an HIE, believe it or not. It could be a very forward-thinking hospital system like Common Spirit. They're trying to do similar things with their collaborations with Pathway Hubs. Kaiser Permanente, United, they all have all kinds of activities that are collaborative in nature on the ground across the country. So it really depends first on who wants to solve the problem together. And I would say, I don't know if you must have my email or something, or Lawrence, email either one of us and we'll send you a bunch of papers. And since you're a smart internal medicine guy, you can read them all in 2 days, but there's a lot on what's out there.
Anything you want to add?
No, I think the whole area of financing in general is kind of we've got a lot of progress that we still have to make. We're seeing a number of organizations that are interested in sort of creative financing using social impact bond models. That really helps in terms of getting upfront capital to build out infrastructure without burden or without pressure on the either grants that are coming in or government resources and so on. So that's a very, very important area to look at. I think there's one's got to be really kind of creative and think and bring in people that have really worked in the creative financing area. And then the other part, which I mentioned earlier, is that you've got to look at on the public side, on the way in which the budget process actually works, and understand that and begin to find ways, solutions to it. That's an enormous barrier right now to getting the kind of financing that we need, and it makes partnerships even more difficult.
Well, with that, I know there's probably much more we could learn from Len and Stuart, but I think we're being told that our time is up, Caroline. But thank you all for your attention.